Welcome to the deep dive. Today we are really cutting through some long-held beliefs, bringing you something genuinely disruptive in healthy aging research. For decades, when we talk about muscle decline, sarcopenia, the whole conversation, whether it's in the doctor's office or the gym, it's been about muscle mass. We worry about losing bulk, right?
Yeah.
The sheer quantity of muscle tissue. It's framed as a weight and size problem. But what if it's distracting us from the real issue? We're diving deep into a prospective study today that flips the script, especially for older adults recovering from serious illness or injury. The data seems to suggest the real culprit isn't just muscle quantity. It might actually be muscle quality, specifically the amount of hidden fat that's woven right into the muscle fibers themselves. So as you're listening, think about this. If you have an older loved one in rehab, maybe after a stroke or a hip fracture, what predicts their recovery better? Is it how much muscle they have overall, or is it how clean, how fat-free the muscle they do have actually is?
That's exactly the pivot this research forces us to confront. We're looking closely at the findings on intramuscular adipose tissue IMAT, specifically in the quadriceps of older hospitalized patients, and the link between the IMAT they found on admission and how well those patients recovered functionally. Well, it turned out to be much stronger than we might have thought. This knowledge, it really could change how we approach rehabilitation fundamentally.
Okay, let's break that down a bit. IMAT. Just so everyone's clear, we're not talking about the fat under your skin, subcutaneous fat, or the visceral fat around your organs. IMAT means fat accumulating inside the actual muscle architecture, like within the muscle bundles.
Precisely. It's fatty infiltration right in the muscle tissue. And this infiltration, it's almost a physiological given. It increases with age, it definitely increases with inactivity, and the kicker is it really hampers the muscle's ability to do its job.
So why the shift now? Why are researchers saying muscle quality measured by this IMAT might be more important than just, how big the muscle is?
Well, it boils down to the outcomes. The data linking high IMAT to negative health events is pretty compelling. Previous studies had already shown that more IMAT is independently tied to things like decreased muscle strength, worse walking ability.
Gait problems.
Exactly, gait abilities, a higher risk of hip fracture starting, and even increased mortality. And what's really striking is that IMAT often predicts these bad outcomes more strongly than just having low muscle mass on its own.
Wow. Okay, that feels like it should already be a standard clinical check, doesn't it? We've been so focused on the scale or maybe tape measures, but maybe we needed to look inside.
Well, major clinical groups are starting to catch on. The European Working Group of Sarcopenia in older people, for example, they've recently really highlighted the need to assess IMAT to get a proper handle on muscle quality, moving beyond just simple mass.
Right. So how do they actually see this hidden fat? You can't exactly biopsy every older person coming into rehab.
No, absolutely not. They use something much more accessible,
Right.
non-invasive ultrasound. It's repeatable, pretty common tech. They measure IMAT using what's called echo intensity.
Echo intensity.
Think of it like the brightness on an ultrasound image. It's measured on a scale, typically 0 to 255. 0 is pure black, that's healthy, dense muscle tissue.
And 255.
255 would be pure white, indicating high fat content, high infiltration. So a higher echo intensity score literally means more IMAT. It confirms the muscle tissue is, well, marbled or clogged with fat.
Got it. So the brighter the image, the more fat inside the muscle. That makes sense. Now let's pivot to the study itself, the design. You mentioned it was prospective, looking at older inpatients. How many people are we talking about?
It was a decent-sized cohort, 404 individuals. And these weren't just generally older folks. They were specifically inpatients, age 65 or older. The median age was quite high, actually, 83.
83, and they were in for rehab.
Correct. Admitted for subacute and convalescent care. So they were recovering from pretty serious events, things like stroke, hip fractures, other fractures like vertebral compression fractures, and pneumonia were common diagnoses.
So a very vulnerable group, definitely not your average healthy older adult population.
No, definitely not. These are individuals facing a really significant challenge just to get back to some level of independence.
And the researchers focused specifically on the quadriceps muscle group, the big muscles on the front of the thigh, like the rectus femoris and vastus intermedius. Why the quads in particular?
Good question. The quads are absolutely crucial for basic movement, standing up, walking, balance. Gait stability relies heavily on them. Plus, they're known to be particularly susceptible to age-related decline, atrophy, and also this specific kind of fatty infiltration, the IMAT, especially when people are inactive, like during a hospital stay.
Okay, so they measured two key things on admission. The IMAT in the quads, using that echo intensity,
Right.
and muscle mass using quadriceps thickness, also measured by ultrasound.
Exactly. Quadriceps thickness served as their proxy for muscle quantity or mass.
And then they tracked how these patients recovered. How did they define recovery?
They used a really well-established clinical tool, the Barthel Index, or BI. It's standard practice in many rehab settings.
Right, I've heard of that. It covers basic daily tasks.
Yes, it scores 10 basic activities of daily living ADLs, things like feeding yourself, bathing, dressing, walking, using the toilet bladder, and bowel control. You get the picture.
And the scale is 0 to 100.
Yep. 0 means completely dependent, needing help with everything. 100 means fully independent in those basic ADLs.
Now, the study didn't just look at the final score, did it? They looked at recovery in a few different ways. Why was that important?
That's a really crucial point about the study's rigor. Just looking at the final score at discharge doesn't tell the whole story. Someone might end up with a decent score but took a very long time to get there. So they analyzed 3 distinct recovery metrics, all based on the Barthel Index. First, the simple BI score at the point of discharge. Second, the change in the BI score from admission to discharge, so how much function they actually gained. And third, BI efficiency, that's the score change divided by how long they were in the hospital. It basically measures the speed or rate of recovery.
Okay, so that gives a much more complete picture. It covers how much they recovered and how quickly.
Exactly. Using all 3 makes the findings much more robust. It helps show if IMAT affects the final destination, the journey, or both. And we have to remember the starting point for these patients. The median BI score when they were admitted was just 40.
40 out of 100.
Yeah, which indicates, pretty severe dependency. These folks were relying heavily on others for most basic daily tasks before rehab even started.
Okay, that context is vital. So, highly dependent, older adults, post-serious illness or injury. All right, let's get to the core findings. This is where, as you said, the narrative really shifts. Before we dive into the numbers, talk a bit about the analysis. These patients were complex, old, often frail, maybe malnourished, lots of other health issues. How did the researchers make sure they were really isolating the effect of IMAT versus all that other stuff?
That was the critical step, isolating the effect. And it's why the multiple regression analysis they used is so important here. They didn't just look at simple correlations. They built statistical models that simultaneously accounted for a whole host of other factors, potential confounders, things like age, sex, their nutritional status, which they measured using something called the Geriatric Nutritional Risk Index, or GNRI.
Okay.
The severity of their main illness, markers of inflammation in the body, even the number of different medications they were taking, they controlled for all of that.
So they really tried to level the playing field statistically to see if IMAT had an independent effect beyond all those other factors.
Precisely. Without that careful adjustment, you could easily argue that any link was just due to, say, sicker or older patients having both more IMAT and worse recovery. This analysis aimed to tease out IMAT's specific contribution.
Okay, the stage is set. Let's hear the results, starting with the traditional measure, muscle mass. What did they find about quadriceps thickness?
This is finding number 2, but it's almost the headline grabber because it goes against convention. Quadriceps thickness. Their measure of muscle mass was not independently associated with recovery.
Not at all.
Not significantly in any of their 3 recovery metrics. It didn't predict the final BI score at discharge. It didn't predict the amount of improvement. And it didn't predict the efficiency or speed of recovery once all those other factors are accounted for.
Wow. So just having bigger thigh muscles in this vulnerable group didn't mean you'd recover better functionally.
Basically, yes.
Yeah.
That's what the adjusted analysis showed. Muscle size on its own wasn't the predictor of functional outcome in this context.
That completely undermines decades of focusing primarily on sarcopenia purely through the lens of size, doesn't it? So if muscle size wasn't the predictor, what was?
That brings us to finding 1, IMAT, the quadriceps echo intensity. Remember, higher score means more fat infiltration. That was the dominant factor. IMAT was found to be independently and significantly associated with worse recovery across all 3 of those ADL metrics we discussed.
All 3. So higher fat infiltration meant lower final score, less overall improvement, and slower improvement.
Correct. For example, when they looked at the total change in the Barthel Index score, the amount of improvement, the standardized partial regression coefficient for echo intensity, was negative 0.23.
Okay, negative 0.23. What does that mean in practical terms?
It indicates a moderate but statistically significant negative relationship. Simply put, the more fat clogging up the muscle fibers at the start of rehab, the less functional ground that patient managed to regain during their hospital stay, even after accounting for age, nutrition, illness severity, and so on.
So The amount of this intramuscular fat seems to be a stronger indicator of how someone's recovery will go than the actual amount of muscle they have, at least in this patient group. Why do you think muscle thickness failed as a predictor here? What's the hypothesis?
Well, the researchers suggest that measuring thickness alone can be misleading. Think about it. If a patient's quadriceps are thick, but a significant portion of that thickness isn't functional muscle tissue, but rather this non-contractile fat, IMAT.
Right, the measurement looks good, but it's not all useful tissue.
Exactly. The thickness measurement might overestimate the patient's actual functional muscle capacity. The IMAT essentially acts like dead weight, or maybe like internal friction, hindering the function of the remaining muscle fibers. It negates the potential benefit of having more overall bulk if that bulk is compromised.
That makes intuitive sense. It's not just about volume, it's about the quality of that volume.
Precisely.
Now, you mentioned they looked at sex differences too. There's a slight nuance with the male patients.
Yes, a subtle point in the detailed results. When they looked specifically at the male subgroup, IMAT wasn't significantly related to the absolute BI score at discharge. It was still significantly related to the amount of change in the efficiency of recovery in men, though.
Okay, so still linked to how much and how fast they improved, just not the final endpoint score in men alone.
Correct. And importantly, when they compared the strength of the underlying relationships, those standardized coefficients, they were actually pretty similar across the male-only, female-only, and the combined group analyses.
So the overall message holds.
Yes, the main conclusion remains solid across the board. Muscle quality, assessed via IMAT, appears to be a superior predictor of functional recovery in this setting compared to just muscle quantity or thickness.
Okay, let's talk implications. What does this mean for the doctors, nurses, physical therapists working on rehab wards right now?
Well, the immediate takeaway is pretty stark. IMAT is a critical, measurable predictor of worse recovery in these activities of daily living. We probably can't afford to ignore muscle quality any longer. The results really underscore the need for healthcare providers, especially in geriatric and rehab settings, to think about integrating assessments of muscle quality, specifically IMAT, maybe via ultrasound, into their routine admission workups.
So if a patient comes in and their ultrasound shows high echo intensity, high IMAT,
Then we know, right from the outset, that this patient is likely at a higher risk for poor functional outcomes or a slower, more difficult rehabilitation process, regardless of how bulky their muscles might seem initially.
which logically shifts the focus for interventions, right? It moves from how do we just build mass to something more like how do we first clean out this fat? How do we reduce the IMAT?
That's the implication, yes. The focus might need to shift towards interventions specifically designed to improve muscle quality.
And the paper touches on potential ways to do that, referencing other studies. What kind of interventions are we talking about?
Yeah, they reference prior work suggesting possible avenues. For instance, some studies have shown that structured physical activity, particularly resistance training, combined with specific nutritional support like adequate protein, maybe whey protein, and the vitamin D supplementation, can actually improve IMAT levels, reducing that fatty infiltration in older adults who have mobility issues.
Okay, so exercise and nutrition. Any other nutritional angles?
There was also a mention of another study where a supplementation with branched-chain amino acids, BCAAs, seemed to reduce IMAT in the back muscles, the lumbar muscles, of patients who had liver cirrhosis, another condition often associated with muscle wasting and poor quality.
Interesting. So the potential interventions revolve around optimizing physical activity and nutritional status, perhaps with targeted supplements.
That seems to be the general direction suggested, yes. It's still speculative in terms of definitively improving ADL outcomes via IMAT reduction in this specific inpatient population, but the hypothesis is strong.
The idea being you might need to declog the muscle first.
Potentially, yeah. You might need to improve the quality and reduce that fat infiltration before the muscle can even respond effectively to exercise aimed at building strength or mass. Clean the engine before you try to tune it up, perhaps.
So what's the next research step needed to confirm this?
The crucial next step, as the researchers rightly point out, is a randomized controlled trial, an RCT. This current study established a strong predictive link, a correlation. But an RCT is needed to prove causation. You need to take similar patients, randomly assign some to an intervention specifically designed to lower IMAT, like targeted exercise and nutrition, and compare their ADL recovery to a control group receiving standard care.
And if the intervention group shows significantly better functional recovery,
Then you have strong evidence that reducing IMAT causes improved ADL recovery. That would bridge the gap from prediction to truly actionable, evidence-based treatment protocols targeting muscle quality.
Okay, let's wrap this up. To summarize our deep dive today, the perspective really needs to shift, doesn't it? When we're looking at health, aging, and especially recovery in older, vulnerable adults, the hidden enemy might not just be the loss of muscle size overall. It seems increasingly likely that it's the fat infiltration within the muscle fibers, the IMAT, that's really compromising function and hindering recovery. So, the key takeaway for you listening is this. Higher levels of fat inside the quadriceps muscle at the time of hospital admission are now strongly implicated as a predictor for worse functional recovery later on. Using ultrasound to assess this IMAT could, and perhaps should, become a vital part of clinical assessments for older inpatients.
Absolutely. And maybe here's a final provocative thought to leave you with. We noted earlier that this study group wasn't just functionally dependent. They were also largely at risk of malnutrition. Their median nutritional score, the GNRI, indicated moderate risk. Now, connect the dots. We know IMAT predicts poor recovery. We know poor nutrition is linked to poor muscle health, potentially including higher IMAT. So how much could we change the recovery trajectory if we implemented really targeted, individualized nutritional interventions aggressively right from day one of admission, maybe even before standard physical rehab gets fully underway?
You're suggesting tackling the potential nutritional root of poor muscle quality immediately.
It raises the question, doesn't it? Could optimizing nutrition specifically to combat IMAP provide a powerful, perhaps currently underutilized lever to improve functional recovery? It seems plausible that part of the answer to getting patients back on their feet might be found much earlier, perhaps starting with what's on their meal tray alongside the work done in the therapy room.